Okay, so previously we've discussed ACE inhibitors. Now we're going to go to the next drug category, the angiotensin receptor antagonist, or the ARBs, ARBs. And so this is just to kind of briefly summarize. Here you've got the effects of angiotensin, or the activation of angiotensin 2 via the enzyme ACE. And of course, we're going to inhibit it with an ACE inhibitor. And then another mechanistic approach to inhibiting the effects of angiotensin 2 is to go after the receptor. And I just want to reiterate that ACE inhibitors go after the ligand of angiotensin 2, whereas ARBs go after the receptor. That's an important kind of distinction to remember, which hopefully will make sense after we go through this lecture series. And so you can come back to this chart and kind of look at all the different molecular targets. Of course, there's beta-1 receptor antagonists as well, as to how they fit into relieving or reducing those compensatory responses that really kind of drive heart failure. All right, so ARBs is the next drug category or drug class that we'll discuss. All right, and so those effects of angiotensin 2 we said are important to block. Okay, and so those are the things that are kind of really driving the effects of angiotensin 2 are really the kind of things that are driving those compensatory responses. And they do so after they bind to their specific receptor. And so angiotensin 2 binds to the AT1 receptor, and then that actually causes physiological changes, which are listed here. And so vascular smooth muscle contraction, the release of aldosterone, as well as the remodeling and hypertrophic growth of cardiac ventricular muscle. Okay, and so angiotensin 2 receptor antagonist, or ARBs, the prototypes are the sartans, not Satan, but sartans. Losartan, valsartan are kind of the oldest in the category. There's a few more listed there. And the reason these particular drugs were developed is because there were some patients who just could not tolerate ACE inhibitors. Okay, we know that inhibiting the production of angiotensin 2 is really an important molecular target, but just clinically, there are some patients who cannot tolerate ACE inhibitors. And so this offers another therapeutic approach. And so if you look at the guidelines, the top tier guideline is an ACE inhibitor, and typically most patients are started on that drug due to angioedema, due to cough, due to changes in serum potassium. You will see them being removed from ACE inhibitor therapy and be placed on ARB therapy. So they'll go from something like captopril to valsartan. All right. And so, as I said before, the prototype was valsartan. And so here we're looking at inhibition of the angiotensin receptor. Okay, and this is with high affinity. And so now we're blocking the signal from angiotensin 2. So at this point, if the patient's on an ARB, they still have biologically active angiotensin 2 circulating, okay, because presumably they're off the ACE inhibitor. However, we're going to be inhibiting the angiotensin receptor. Okay, and so no matter how much angiotensin 2 is floating around, we're going to be blocking the receptor. So none of the physiologic changes that are associated with angiotensin 2 binding can occur. Okay, there are 2 receptor subtypes. Mechanistically, we're really focusing on the AT1 receptor because this is kind of the receptor that is really kind of driving the pathophysiology. Okay, so then these drugs are ideal for the patient population with heart failure, okay, who cannot tolerate, for whatever reason, ACE inhibitors. And so remember, ARBs are alternatives to ACE inhibitors. We really wouldn't want to combine both an ACE inhibitor and an ARB. It has been done in the past clinically for a special group of patients, but it's not recommended because you're going to get really potent inhibition of the renin-angiotensin-aldosterone system. And these drugs were not designed to be together. They're designed to be alternatives to each other. So just keep that in mind. Okay, so here we see more selective angiotensin inhibiting effects than ACE inhibitors. The other pharmacology is pretty similar to ACE inhibitors in terms of what they're used for and the clinical effects. The incidence of cough and angioedema, although possible, is much less common with ARBs. And there's no effect on bradykinin metabolism. And so we'll kind of expand on that in the later sections, but it's believed that the dry cough that's experienced with ACE inhibitor therapy is really coming from the inhibition of ACE in the lung compartment. And so here you're kind of deactivating bradykinin through an ACE inhibitor. So if you use an ARB, there's really no effect on bradykinin because remember, angiotensin 2 is still biologically active, and ACE is biologically active if you're using an ARB. Okay, and so again, we're using these drugs for patients that need inhibition of the system, but who cannot tolerate ACE inhibitors. Okay, so I said we don't want to combine them. There's a higher incidence of adverse effects. You don't want to use them in pregnant patients. Okay. However, ARBs do have a slightly higher rate or slightly higher incidence of hypotensive symptoms, more dramatically encountered than ACE inhibitors. Okay. And as I said earlier, there's lower rates of angioedema and cough, which are really kind of the two main complaints in terms of ACE inhibitors. Okay, so how does this work? And so we, mechanistically, we like to go through, at least from the pharmacology side, we like to go through and show you the step-by-step physiologic changes that occur that produce these compensatory responses that we're talking about. We tend to kind of skip it in the pharmacology for the ACE inhibitors and the ARBs because it's just so complicated. And so this is really molecular biology from hell, and we're looking at the concept here where angiotensin 2 is basically binding to an angiotensin receptor. Excuse me. And of course, this is a G protein coupled receptor, and you get changes within the cell that basically drive some of these responses. And so the ERK signaling pathway contributes to fibrosis and hypertrophy of the left ventricular cardiac muscle. Some of these Rho GTPases contribute to inflammation. And its effect on myosin light chain kinase and myosin light chain basically produce contraction and possibly migration and hypertrophy of the muscle. And so you can see lots of cellular processes being mediated by what's called a signal cascade, which you've probably been introduced to at some point either in physiology or at least some part of pathophysiology. And so mechanistically, this is how they work. We don't ask you the details because it's long and complicated, but if you were wondering, here's how they work. Okay, and then here's the summary figure that was cut from the textbook explaining the previous slide. Okay, so that kind of summarizes angiotensin 2 or AT1 receptor antagonists, or ARBs. We will now transition over to the next category of drugs, the vasodilators, including isosorbide dinitrate and hydralazine.